We'll go ahead and get some things started. We have a few orientation slides and some housekeeping information to go over before we jump in, and we give folks a few moments to log in. By way of introduction, let me first start with myself. My name is Brandy Clark, and I am the project director of the Mid-America Mental Health Technology Transfer Center, located at the Monroe-Meyer Institute at the University of Nebraska Medical Center. I'm very pleased to be your host for the day, our second day of our Organizational Wellbeing in Healthcare National Symposium. We want to welcome our panel of speakers here today, as well as all of you in the audience. We thank you for your engagement today, and we hope for this to be a day of some lively interaction and back and forth. So please feel free to use the chat feature today and engage with us all. Our first day of our symposium was a day focused on increasing awareness and understanding of the need for systemic organizational well-being approaches within healthcare to address these critical issues that we're seeing related to resilience and burnout. Our focus today is going to be to provide an opportunity for teams within our healthcare systems to engage with that information and to do some guided strategic planning with some folks in the field around how to establish or improve systemic programming within your systems. We're really excited that today we also are going to introduce you to a newly developed organizational well-being inventory. And you're going to get the opportunity to interact with the developers around that inventory to take some opportunity to pilot with it and provide some feedback. So this is an exciting opportunity, and we're glad you're here to join us for it. So just to start off, we have a few housekeeping items to make you aware of. We've made every attempt we can to make today's presentation secure. If we need to end the presentation unexpectedly, we will follow up with you using your registration information. It's our hope that we won't have to do that. If you have a question for presenters today, please use the chat box feature. You can also use that if you have a comment that you want to share or a link to share with others. Please use the chat box and to engage in that way. We hope to see some lively chat today. The session recording and slide deck will be posted on our website within about 2 weeks of our presentation today, so you will have access to all of the information. If you attend at least half of the session today, you will also receive an email following the presentation that will give you access to a certificate of attendance. And last but not least, if you haven't already, please follow our social media, follow us on social media so we can stay connected with you beyond our event today. So let me introduce a little bit about who we are at the MHTTC. So we are a SAMHSA-funded MHTTC network that focuses on technology transfer. And what we mean by that is the adoption and implementation of evidence-based practices for mental health across the United States and our territories. And our goal is to develop and disseminate resources to provide free, local, and regional training and technical assistance for the mental health workforce. In our next slide here, you'll be able to see the map of our network and displaying where all of our centers are located. So if you're joining us today, please take a moment just to see where your MHTTC is. You notice we have 10 regional centers, a National American Indian and Alaskan Native Center, a National Hispanic and Latino Center, and a network coordinating office. So please visit our website, find the center where you are located so that you can get access to information on trainings and resources that are being offered in your region. Some information that we just want to make you aware of, that our presentation today was prepared for the MHTTC network under a cooperative agreement from the Substance Abuse and Mental Health Services Administration, also known as SAMHSA. And all of the opinions expressed in this presentation, they're the views of our speakers. They do not reflect the official position of the Department of Health and Human Services or SAMHSA. So to start off our day today, we wanted to engage in some discussion with a panel of folks who could present some national perspectives on how to improve organizational responses to health professionals' well-being. We have an esteemed panel with us today that we're really excited to hear from. including Dr. Ashley Stewart, who is an adjunct expert and trainer and curriculum development specialist at C4 Innovations. We have Dr. Lauren Peccoralo, who is a senior associate dean for faculty well-being and development, and an associate professor in the departments of medicine and medical education at the Icahn School of Medicine at Mount Sinai. We also have with us Dr. Carol Bernstein, who is a professor and vice chair for faculty development and well-being, departments of psychiatry and behavioral science and obstetrics and gynecology and women's health at the Montefiore Medical Center, Albert Einstein College of Medicine. That's quite a mouthful, Dr. Bernstein. She's also a senior scholar in the Department of Education and Organizational Development for the Accreditation Council of Graduate Medical Education. We also have with us today Dr. Andrew McLean, who is the chair of the Department of Psychiatry and Behavioral Science at UND School of Medicine and Health Sciences, and Dr. Steve Wengel, who is a professor in the Department of Psychiatry at the University of Nebraska Medical Center, and the first ever assistant vice chancellor for campus wellness for UNMC and the University of Nebraska, Omaha. And today we're lucky to have with us as a moderator for this panel, Dr. Jeffrey Gold, who is the chancellor of the University of Nebraska Medical Center, vice president of the University of Nebraska System, and chair of the board of UNMC's Principal Clinical Care Academic Health System partner, Nebraska Medicine. He also serves on several key national Academia of Science, Engineering, and Medicine steering committees, including the Clinician Wellbeing Task Force, the COVID-19 Task Force, and the All Hazard 21st Century Threats Task Force. He's also been very active in the national implementation and national level in multiple education research and clinical COVID-19 pandemic response, with hundreds of educational and media appearances, webinars, congressional department agency hearings, and briefings. That is a mouthful. You can tell my mouth's already tired just doing introductions today. That's why all of you are an esteemed panel here with us for this presentation, because of your background, your knowledge, and your expertise. And we're very grateful that you're willing to share that here with us. So at this point in time, I'm going to go ahead and turn our conversation over to Chancellor Gold, who will go ahead and moderate our panel for today.
Well, thank you so much, Dr. Clark. I really appreciate that introduction. It's never brief enough by my standards. And you might wonder why the chancellor of a university and somebody with my background as a nearly recovered cardiac surgeon might be willing to be the convener of this panel. And of course, all the knowledge is in the panel level, not mine. But it's an area that I've cared about deeply through all of my work in different accrediting bodies for undergraduate and graduate education, through my extensive experience in the totally non-health professions areas, which have been devastated not only by the pandemic, but by all sorts of well-being challenges. And so when Dr. Clark asked me if I'd be willing to join you this morning, I really jumped at the occasion. I might point out, though, that on a more formal level, and if I can just share my screen just for a minute before we get into our panel discussion, I'd like to share with you this one graphic. And this is very much a work in progress, but it gives you a bit of an idea as to where the National Academy of Medicine Clinician Wellbeing Working Groups are organized, how they're organized today. This has been a multi-year process, actually convened by Victor Zhao, who is the president of the National Academy of Medicine, with co-leadership by Dr. Daryl Kirsch, the immediate past president of the AAMC, Dr. Tom Naska, the president and CEO of the ACGME, and most recently, Dr. Vivek Murthy, the United States Surgeon General, is now one of the key leaders of this. I have the great honor of being on the one of the co-leaders of the National Strategy Work Group, which is focused on building the national strategy But I share this, and there are two other work groups. There's one on implementation, and there's one specific to COVID-19, and I'll show you why in just a second. But I think this graphic really makes the point that the patient and healthcare are in the center of this, surrounded by those that are frontline in the delivery of that care, surrounded by the organizational structures and systems that make that frontline care delivery possible, and then surrounded by, if you will, the national culture around health and well-being, and the overall, in this case, for one of our working groups, pandemic recovery. So just to give you the aims of each of these three working groups, which comprise in total somewhere between 125 and 135 leaders across the United States. Tate Shannonfeld, for instance, is my co-lead on the National Strategy Group, which is aimed to create a national strategy for clinician well-being by mobilizing and sustaining engagement, resources, and accountability of key healthcare stakeholders. The implementation group has an aim to catalyze uptake of evidence-based practices and implement tools to support healthcare leaders in improving clinician well-being on the front lines of care. And the COVID work group is to support the healthcare workforce and apply emerging lessons from COVID-19 with continuous feedback loops to develop long-term approaches. The idea here is to communicate, to create accountability and responsibility, and then, of course, to create substantial resources directly related to funds that are available, not only through the COVID-19 ARA Act and so many others, but by direct executive level, meaning White House level appropriation of funds through the Office of the Surgeon General, but also directly through congressional awareness and congressional action as well, drill down to the state level and so many others. And so I'm really proud to play a small part with the National Academy of Medicine in this, because I do believe that this process, in conjunction with what your groups are doing and so many others, is really going to put teeth into this process to make it both effective and sustainable. So we've got a great panel of experts. I'm going to stop sharing. And what my job is pretty simple, as Dr. Clark has outlined it, is we have 4 questions that we're going to ask our esteemed panel of experts to respond to, and then we're going to reserve some time for some Q&A, comments, and discussion from the group, which will be moderated by Dr. Clark. And so the first question, and just to let you know, the panelists are aware of these questions. These are, no one's being blindsided today, although we could go down certain paths, who knows, we'll find out. But the first is to, for each of our panelists to please tell us a little bit about who you are and the work that you're doing regarding professional and organizational well-being. And why don't we get started? We'll start, well, I guess I'm told we'll start with Dr. McLean.
Great. Well, thanks, Dr. Gold, and thanks everyone for allowing.
By the way, other than my grandchildren who call me Grandpa, everybody calls me Jeff. So please feel free.
Thanks, Jeff. People
Carol
can hear me
knows
okay?
all too well.
All right. People can hear me okay?
Yes, sir.
Great. So, you know, I'm informed certainly by my background. I'm the son of a country doc who said that half of what he did was mental health work and he didn't know what he was doing. And so I'm certainly aware of the stresses on care providers, having grown up in that environment. I was an orderly first. I became a psychiatrist and was the medical director for our state's Department of Human Services, working with high need populations. During that time, we had a number of natural disasters. And so I became involved in disaster mental health as well. So not only was I interested in individual care, but also individual resilience, but also community and organizational resilience as well, which prompted me to get my MPH. I also was on our medical licensing board. And at the time, we separated the professional health program from the medical licensing board to incentivize people, providers, to step forward and not feel hindered in terms of taking care of their mental health, which is an important point, I think, for everyone. Dr. Gold, or Jeff, you mentioned accreditation. I'm very interested in your group. I actually survey for the Joint Commission, and I've been part of a work group on physician wellness and what the organization can do to enhance that and reduce barriers within the credentialing and privileging processes, as well as at higher levels. I've been involved in medical student and physician well-being, have worked with the MHTTC in Mountain Plains on individual and community resilience, and also have been working with the Transformational Resilience Group on climate change and mental health. So that's my background.
Super. Well, thank you so much. Dr. Bernstein, would you give us a little background?
Thank you so much, Jeff. And as Jeff mentioned, he and I go way back sort of to the start of all of this. I'm also a psychiatrist like Dr. McLean, but I've been involved in graduate medical education my entire career. I've been a training director at several institutions and also involved with medical student education. I was fortunate enough to be on the ACGME Board of Directors when Dr. Gold was on it as well. And way back in, gosh, now I think it's 2013, there were 2 intern suicides in New York that many of you have probably heard about. And the ACGME really took this issue up. I was the only psychiatrist on the board at the time. And I remember thinking, wow, if we could get doctors to look at themselves and their own mental health, they would do a much better job of taking care of the mental health of our patients, which has really struggled around stigma for centuries, as you all know. And I think we're in a different place now for some sad reasons, but some good reasons as well. So I was really involved with the ACGME at the outset when we first had our national symposia on physician well-being. Dr. Naska and Dr. Kirsch kind of brought people together initially. They enlisted Dr. Zhao, feeling like this really had to be a national movement if it was going to have any legs. Little did we know that COVID was going to be a rocket launcher at the end that was really going to accelerate what we were doing. So I've also been involved, as Jeff has been, with the National Academy's Action Collaborative on clinician well-being, really from the beginning. I sit on the COVID-19 task force that Jeff alluded to. For many years, I was at NYU involved as the DIO for graduate medical education and the residency director in psychiatry, and moved over to Montefiore Medical Center 2 years ago as the vice, as you heard, as the vice chair for faculty development and well-being in 2 departments. I've also been involved there with the DIO and with the GME community, and I'm now I'm chairing the GME subcommittee on well-being. I was also directly involved with leading the support initiatives around how to support our staff during the COVID-19 crisis. And sort of what I see has happened is that we started off with a focus on clinician well-being that was jump-started by suicides, but which has really been a longstanding challenge for our healthcare workforce. And I'm really glad in that respect that there has been a national and now even an international focus on this. I think what COVID has done, as I mentioned, is that it has accelerated the process. And what's going to be really important in the long term is to see how we can take the lessons that we've learned from COVID and translate them into ongoing support for our healthcare workforce. We still struggle around stigma. Even what's happened at the Olympics with Simone Biles, I think, has been really important. I think the issues of mental health and well-being and how we find meaning and connection in all of our work, specifically in mental health, is now really front and center. And I'm very pleased and privileged to be part of this, group here, this panel, and to learn from all of you. And I look forward to our ongoing discussion.
Thank you. Next on my list would be Dr. Stephen Wengel. By the way, I have no idea how this order was created, so I'll disavow any responsibility. Steve?
Well, good morning, everyone. Thank you, Jeff, for that introduction. And So we're kind of front-loading the introductions with psychiatrists. So I am also a psychiatrist, a geriatric psychiatrist, just celebrated my 30-year service anniversary here. And liked what you said, Jeff, about you being a recovering cardiac surgeon. I sometimes describe myself as a recovering department chair. I had that honor for about 14 years. So Andrew, I know what that's like, but 3 years ago, shifted over to this new role that you created. And I'm honored and privileged and have been doing that for about 3 years, was being sort of a campus wellness champion, if you will. But I've been interested in this field for a long time myself too. As a psychiatrist, I have counseled many patients on like stress management techniques over and above medications that we prescribe. And probably about 8 or 10 years ago, I helped develop a stress management elective for our medical students because, as we all know, medical training, whether it's medical school, nursing school, pharmacy, is stressful. High rates of burnout, 10% rate of suicidal ideation in medical students, for example, in any given year, and all those. And we heard about actual completed suicide from Carol, something I've been deeply concerned about for many years. So when we developed this medical student elective, it quickly became one of the most popular electives at our institution for our medical students, which was kind of a signal to me that burnout, stress, and so forth has been a big issue for healthcare trainees and professionals. So in any event, lately in the last 3 years since I've been doing this more dedicated wellness position, I've been looking for a strategy or a set of strategies, and I'm happy to say I borrowed or stole some ideas from Carol, a great paper she published or co-authored a couple of years ago, looking at burnout as like a public health crisis, and looking at it and then using public health strategies like prevention, screening, and treatment. So that's been kind of my basic philosophy as we design programs, try to cover each of those 3 areas. So prevention, giving a lot of resilience talks and a lot of education, screening, peer support programs and self-screening apps and things like that. And then at the top of the pyramid, treatment, how do we reduce barriers for physicians, students, and our staff? More to follow on those, but that's kind of a bit of a backdrop.
Thank you. Next on my list would be Dr. Stewart.
Thank you so much, and thank you for the opportunity to be here. My research is primarily at looking at organizational well-being through the lens of institutionalized forms of identity-based oppression, how to reduce those barriers to increase well-being, and looking at the compounding impact of identity-based oppression and racism on a lot of the topics that we're talking about, the burnout, the mental health concerns, the health disparities for healthcare workers and healthcare professionals. I'm an assistant professor and the program director for the Masters of Social Work program at Temple University College of Public Health School, Social Work. And in that capacity, working to train folks planning to enter into the field of social work, but also interdisciplinary students as well, and looking at the critical disparities that exist around identity-based oppression, systemic and structural forms of inequities, and what can our individual responses as well as institutional responses look like to increase well-being within organizations. I find that it's a topic that a lot of folks stray away from, but I've also seen the results in terms of creating culture shift and organizational well-being to be profound when we can have open and honest conversations about compounding traumas that are existing. At C4 Innovations, I have the wonderful opportunity to do a lot of training and curriculum development around racial equity in a multitude of different spaces, primarily in spaces discussing recovery. And so this is something that I think about a lot in terms of organizational well-being and how do we begin to respond to some of our societal inequities that absolutely impact the healthcare. Thank you.
Thank you. Appreciate it. Now, Dr. Peccarallo.
Hi, good morning. Thank you for having me. And thank you all to my previous panelists who have so much experience in this work. So I'm a primary care physician. I began sort of thinking about this when I created an integrated behavioral health program in our primary care clinic way back in 2011. Eventually, sort of circuitous path led me to creating a well-being committee within our division. And fortunately or unfortunately, the circumstances such that Carol mentioned with many suicides in New York City and a number of them in our own institution really put to the forefront the need for well-being programming. And so at the time in 2018, Dr. Jonathan Ripp became the CWO of Mount Sinai, and I was fortunate enough to become the Associate Dean for Faculty Wellbeing at the time. And so since then, we've really worked to develop a structured approach to well-being in the institution, really focusing on sort of an organizational and departmental level strategy. So yes, of course, we're thinking about resilience building and mental health. Those are two really important elements. But we're also thinking about, how do we really influence the efficiency of practice across the board? How do we change the culture of our institution into really truly believing that well-being is important? And it's not just for obviously the physicians, right? It's for the entire healthcare workforce. So we've built well-being champion structures, both at the hospital site level and at the department level. And we're working on actually doing that with the nursing level next. But I think, as everyone has said, COVID has really launched us forward in this work. And so during COVID, we sort of did two main efforts. One was to utilize a survey to really understand the needs of our workforce. And we utilized the results of that survey to really institute a number of different programs to help folks during COVID. And then we also were able to publish on a number of really interesting findings related to COVID, specifically around COVID-related stress, in the first wave, and we're working on our second wave paper in terms of what we see trajectory-wise, right? We see a lot of mental health symptomatology really early on, and then that sort of falls off, but the burnout goes up. And the other point I wanted to make was that I think what Dr. Stewart mentioned is so important right now, that we can't think of these things in silos. We have to think of well-being. We have to think of systemic racism and anti-racism efforts all together, because they are critically important to creating that safe environment that everyone feels comfortable being able to speak their mind and speak their truth. So we're working very closely with our Office of Diversity and Inclusion, our Office of Gender Equity, and also our quality improvement folks to really unify all the approaches, because they all play into the well-being of our workforce. So that's it. Thank you.
Well, thank you. And that's actually a great segue into the second of the questions that I'd like some of our panelists to address. And that is, what do you see as the most substantial national trends related to professional well-being in healthcare? And specifically, how has COVID shifted the landscape of professional well-being? And what I mean by that are, it's obviously created challenges, but has it also created opportunities? And maybe Dr. Peccarallo, you could start, and given the research that you've just described, and we'll pick on one or two others to share some thoughts as well.
Sure, I'm happy to. I mean, I think for our institution, it was really clear pretty much at the onset of COVID, we were tasked with bringing together a task force of numerous folks across the institution to try to really think about how we could improve and dampen the effects that COVID was having on our workforce. And like I said, it's critical to include all of the workforce, right? So nursing, administrative, transport, nutrition services, all of that, everyone has to be at the table. And it also is critical to be thinking about the other dimensions, right? So where's gender equity falling out? Where is anti-racism falling out in this? And simultaneously, right, we had a pandemic of, this crazy proportion of COVID, and then we were having an epidemic of racism, police violence, and you can't divorce the two, right? They're happening together they're probably interacting with each other, and they're affecting our patients and the workforce. So we tried as best we could to really bring these two together. And what I'll say is we haven't figured it out, we haven't solved any problems, but what we're doing is we have constant communication, right? We are just constantly in communication with our Office of Diversity and Inclusion, with the Office of Gender Equity, with our nursing colleagues, and just trying to move efforts forward with large groups, pushing them forward, which is actually great. So I think that's the opportunity there, is that it's brought people together that maybe would have taken a little bit longer to come together. And with that, we can do a lot more when there's a lot more of us working towards something.
So let me just to stay on this subject, just to ask our other panelists, maybe some thoughts on what I've heard described as the profound moral injury by those that are so vaccine hesitant, I guess would be one way to describe them, but people that are, I just met so many people, maybe because I'm based where I am in the country, who don't even believe that COVID as a pandemic even exists. They believe it's part of conspiracy theory, and yet when they show up in our emergency rooms, end up on ventilators in our critical care units, the frontline workforce, of course, takes care of them, but there's also clearly an inflicted moral injury. I don't know, Dr. Bernstein, do you have any thoughts on that?
Thank you, Jeff. I mean, I was listening to Lauren. I just want to say at the outset, I'm a little jealous of all of the structures that they have in place in the Mount Sinai system. It really speaks to leadership. And I think, Jeff, that you've provided leadership at Nebraska as well. It's very, very important that leaders lead on this topic. With regard to the moral injury question, I think that that's also profound even within the workforce. I am working in the Bronx. A lot of our staff are people of color and of different genders. And there's tremendous hesitancy in the staff themselves with regard to the vaccine. So we're in a very complicated matrix, and I don't know that there are easy answers to this. I just spent a half an hour on the phone yesterday with the chair of our emergency room talking about this third wave or whatever we're experiencing right now. And for his folks in the ED, it's particularly stressful because now in the first wave, even though we were at the tip of the spear and it was really horrific, support and help came from all around the country. That's just not possible now. So because everybody is struggling with this and every group is struggling with this. So the issues really relate to how do we support the teams that are currently in place when people are getting really demoralized. And we're not seeing shortages of treatment, but it is challenging when people don't choose to get vaccinated for a lot of really valid reasons. And that's why I think you're seeing a lot of effort to go out into the community to try to address that with leaders who are trusted by that community outside of the academic health centers that we all work in. So it's a big challenge. Montefiore, and I don't think Sinai yet, a number of healthcare institutions around the country have now mandated vaccines for their staff. That hasn't happened yet for everyone. There are a lot of challenges related to that. And I think it would be important for us to try to talk about that, certainly given all of the gender equity and racial concerns that Ashley mentioned. I mean, this is all coming in the context of structural racism and structural challenges for both low-income communities and communities of color. And it's very hard to try to fix the problem when there's longstanding suspicion and distrust in the community. And at the same time, that impacts the morale of the healthcare treatment team who's seeing a rise in cases when we had really done so well. So it's a difficult, difficult problem.
So Dr. Stewart, would you like to comment on the perhaps some thoughts about not just the pandemic, but the challenges and opportunities that we're facing today? And I think all of our other speakers have identified the gender and the structural racism aspects of this, but there are obviously also political aspects of it. There are age-related aspects of this, but your thoughts?
Yes, certainly, we're seeing skepticisms around vaccinations across all groups. And I think one of the things that is a challenge and an opportunity is that we have been talking about issues related to racism more. In most of the sessions, I begin with asking folks, who in here has been talking about racism more lately than they have before? And I think it's provided us the context to develop some similar language to understand some of the context, the historical context. And so, in thinking about the connections between moral injury and PTSD or traumatic stress more broadly, one of the things that comes up is about perception. And I like to bring into the conversation that perception is calculated data that people have taken in throughout their lives, whether it's something they have experienced personally or whether that is something that they've seen vicariously. And so how do we have the conversation that needs to happen about distrust by acknowledging the harm that has been done to communities, to address that profoundly, to begin to validate the perception difference that we're seeing. I think that has been one way that we can look at this differently, is about acknowledging harm done to different communities so that the conversation can begin to shift and there be more consistency that is in alignment with being thoughtful and considerate of those harms than continuing to perpetuate them, if that makes sense.
For sure. Thank you very much. So that actually gets us to another subject that we want to discuss, and that is there's a lot of evidence. There's been a good deal of quality peer-reviewed literature, countless meetings, at least that I've attended, and others where people have presented their research and indeed some best practices on dealing with some of these challenges. And I'm one of these people that loves to turn challenge into opportunity. But the question, I think, for our panel is, can you share with us something about the lessons you've learned regarding the implementation of evidence-based practices for not just individual well-being, but for organizational well-being? And maybe we'll start with Dr. McLean at this go-round.
Thanks much, Jeff. I think when we were talking about what works, actually the next couple of talks I'm giving are on trying to use behavioral medicine evidence-based theories to effect change. And so, changing an individual's opinion, we know that the most trusted individual typically within the medical community is their provider, but changing it on a broader scope is much more difficult. I think some of the literature talks also about within organizations that when people are allowed more control, when they don't feel trapped, there are better outcomes. For instance, as we're looking at electronic health records and the burdens on providers, organizations that have allowed more flexibility in schedules for providers to allow them to get back to feeling the essence of why they went into medicine, which itself is a protective factor from burnout. I think that there's certainly evidence there that there is bang for the buck. I think that it pays off to actually trust your providers and allow more freedom, particularly around schedule. And I think that COVID has allowed us to see, the benefits of being able to do some hybrid or some virtual sorts of provision of care while having, a more balanced life.
Dr. Wengel, what do you think about the best practices and the evidence-based ways of changing organizational culture?
Well, yeah, that's something I think a lot about, and I would say it is a challenge for sure. I would say most of I think collectively, well, my efforts and I think many people's efforts has been aimed more at the individual level, because that's where we sometimes feel like we have the most leverage, trying to teach our individual providers and students about signs and symptoms of depression and burnout, and trying to catch problems earlier and provide peer support, all of which are really, really important. But we're doing that in the context, of course, of work environments that are increasingly stressful. Again, even absent the COVID-19 thing, and again, remembering the early parts of the pandemic with people being worried about not having enough PPE and things like that. But just, this work is very stressful. And how do we reduce some of that stress by reducing things like burdensome documentation requirements and such? That's something I think we'll talk about, the panel will be talking about here hopefully shortly. But those are harder things to do. So I think it was, to date at least, a lot of the efforts have been focused more on the individual, like how do we help people work more efficiently with an electronic health record system, for example, that is perhaps not optimized? How do we help those individuals optimize their time? But what we really need to do, I think, is work at a higher level and try to fix the problems that are creating some of the, creating burnout in the first place.
So, Dr. Bernstein, I know you've put a lot of time and effort into systems analysis and things that can occur on the systems level. Maybe you'd share some of those thoughts.
Well, I know that many of you have heard of Christina Maslach and her colleagues who've done sort of the sentinel work in this area, looking at burnout. What they've done that's even more intriguing is they're looking at areas of work factors. I think at this particular point in time, it's not really going to help to measure burnout. We're all fairly burned out from this crisis and in general. But I think what we really need to do is to look at strategies and their impact. And there are a number of areas in the literature, all of which have been alluded to by the panel so far, but certainly workload is the primary driver of burnout. And I think Steve was just talking about this with the EMR and looking at efficiencies in the practice environment. But that's also the most difficult one to change because patients need to be seen, institutions need to be solvent. Everybody's upset now because there's so much pressure now for institutions and systems to see patients and provide care since they were closed for so much of the early part of the pandemic. Outside of that, I think Andrew's already referred to control and autonomy and how important that is. And I think to whatever extent, in whatever setting we can, the literature is strongly in favor of providing local control and autonomy as much as possible. A third area is that of fairness. This also relates, I think, to some of the racial and gender equity piece that we've talked about, but things really need to be fair and transparent. And I think all of that goes to improving what's going on in the system and maybe easier to address directly than the workload question. It's also been shown that connection really has been really important. And one of the biggest challenges in this crisis has been the fact that we have been isolated from each other. That in other disasters, and the disaster literature is full of this, people, sort of come together. There's a hurricane, there's an earthquake, there's something really awful happens and it's over and then people come together. And here we are dealing with an unseen enemy that says we really can't be so connected to each other. And even though Zoom and its similar opportunities are good, we're able to get together now virtually, all of us, it's also really hard. But fostering connection within individual work units, within individual groups is critically important. There is also the value piece that we were talking about before, that there really needs to be consonance between the values of the people in the workforce and the values that leadership is espousing at the top. And I don't want to omit, and I think there's been a lot that's written about this on the systemic level, and I've certainly seen it firsthand. I won't say that leadership is everything, but leadership is essential. Strong leaders driving change, understanding the context, understanding about racial and gender inequities, understanding the pressures on people within the workforce is critical, and believing with their hearts that the health and well-being of the workforce is essential to delivering good patient care is critical. And we will see differences in institutions and systems across the country when leadership is really doing the job, walking the walk, not just talking the talk. I cannot tell you how critically important that is. And finally, I want to mention that in many ways, 99% of life is being there. So to show up, for people to show up in their local arenas, leaders to show up like Jeff is here today. I mean, this goes a long way. It also goes a long way even on the issues that we've talked about with regard to stigma, sharing personal stories, personal narratives of one's own experience and what's been challenging in the pandemic is critically important for all of us. So again, just to sort of summarize, control and autonomy, leadership, transparency, fairness, workload, and connection to each other are among the things that are really critical for organizations to address if we're going to get through this.
Well, thank you for that. So the final question for our panelists, and we're going to hear from all of them, is how should we prioritize? Where should we put our energy, our time, our resources within our organizations? What national initiatives would best meet the needs of the healthcare professionals? And this is really the question that is front and center for the National Academy work groups right now. It's how they're organized. And so let's just say I'm listening and taking notes and learning a lot from each of you. And why don't we start with Dr. Peccarallo, and your thoughts on, what's the biggest bang for the buck, so to speak, of our time, our talent, and our treasure?
Wow, this is a very hard question. I think
Never said it would be easy.
I'm going to put my money on culture right now, because I think if you can shift the culture, I think in many ways what Carol just said, if you can get the real true buy-in from the leaders that this is important, and if you can spend some time, what I call it is well-being infiltration. So getting a well-being representative at every table, who's not just a narrow-minded well-being person, right? Who's thinking broadly about, how do we really think about well-being, integrating, anti-racism, integrating gender inequities, integrating efficiency of practice, integrating personal well-being techniques. But we have to have really well-educated champions, and they need to infiltrate. And that, in my opinion, can begin to shift the culture. I think that's what we're doing in Mount Sinai. I think we still, again, have a long way to go. And there are pockets where this is like, people are so excited about this. And then there are pockets where we're still, pushing people along and trying to get them to come to our side. But well-being culture is critical. And along with that is sort of the leaders buying into it, and the leaders really, as Carol said, being present and being not only present, but also listening, right? Like, I'm not just going to come and sort of tell you how great I am and how great the institution is, and, we're doing so great, but I'm going to say, I'm humble in this work. I am not always correct as a leader. Tell me about what we can do better.
And that's very well said, but I would add to that the leaders need to be held accountable for this by their governing bodies. And we need a culture of that accountability at the governance level. Dr. Stewart, where should we put our resources, our energy, our time, and our talent?
Yeah, I'm just really building off of Dr. Peccarallo. I think I'm also too very much in looking at equitable culture shift and that culture change, not only because it increases well-being, but it increases that consistency that allows the folks who we're serving to feel that as well, more so than just seeing it in practice, but feeling it as terms of like the energy of the culture as well. And I think that one of the places, talk about organizational well-being, it has really good feels to it, right? It seems as though as soon as it gets implemented, we're all going to start to feel better. And I think that in line with what we're talking about with leadership is also the acknowledgement that there's going to be change fatigue, there's going to be resistance, there's going to be discomfort in moving because change is uncomfortable for folk. And I think a lot of times what we'll see is when we begin to push for that equitable shift, that change fatigue sets in, and then we go back to other things that are maybe more comfortable to address right away. So I would say we lean really into that space of discomfort, knowing that what's on the other side of it are people being able to show up authentically, people being able to give their all, be innovative, be creative, and really recreate the way that we're doing things to support and include more folk. So I like to add that in, yeah.
Super, thank you.
Yeah.
Dr. Wengel, what should the priority be? I know you and I have had these conversations for a long time, and you know, as I'm fond of saying, if we have a lot of priorities, we have no priorities. So what should they be? Right.
Well, I think at least in the short run, obviously with the current, you know, rise in COVID cases and all, I think there are many things that are being done and need to continue to be done at a local level to support our providers. You know, providers are really getting tired, and you know, a sense of here we go again. That's kind of the term I've been hearing on our campus here lately. So we need to, you know, obviously I think put our efforts into supporting them in every way we can. We, for example, you know, we have a pandemic partners program, you know, where we pair people up and they have kind of peers, designated peers. We have a peer support program, things like that, that again, have been in business for a while, but we're really have ramped them up, and we're going to continue to need to do so. But at the same time, you know, we need to advocate at a national level for, and again, great to hear of all of your work and your advocacy at, you know, in various national venues to improve the workplace, to, you know, reduce some of the clinical or clerical burden, the administrative burden, so that we can do what people want to do. You know, to me, in some ways, this is really complicated and really, you know, lots of different strategies, but at the end of the day, a lot of times it comes down to time. You know, that's one thing we hear from providers over and over again is the fundamental work that clinical people do is very fulfilling if they have the time to connect with their patients and with one another. As Carol said too, that's the other piece of this that I think is super important, is finding ways to have authentic connection between providers. It's one of the antidotes to burnout, I think.
Thank you. Dr. McLean, what's the priority need to be?
You know, I think I'm more optimistic about change at a local and organizational level than I am national, but certainly the national leadership needs to be involved. But it's much easier to, you know, change the direction of a rowboat than a tanker. And at the national level, there seem to be, you know, many more politics, the imbalance in terms of who has power and voice. And so, you know, I think that working at local, regional, organizational areas is probably, and giving them the resources to do so, probably has the greatest bang for the buck, in my opinion. I certainly don't want to negate the work that you're doing, and would certainly like to contribute, but my money is on local.
For sure. And indeed, there's so much diversity across the nation in different centers that while there may be many common themes, the detail is going to be extremely local. Dr. Bernstein, how should we prioritize?
Well, I think that the underlying key here are resources, that I agree completely about the culture change issue. I also agree about the discomfort with change that Ashley alluded to. I mean, all of this is complicated, but there needs to be leadership at both the national and the local levels. I agree with Andrew, you know, all politics are local, no question, but it has to be both top down and bottom up. It can't be one or the other. It really has to go both ways. And there has to be a commitment. I mean, people keep talking about, you know, what's the ROI? What's the return on investment? And I'm like, all you have to do is look at recruitment and retention in healthcare. I mean, if you just looked at that barometer alone, that's going to tell you whether you're doing a good job at taking care of your staff or not. And resources, we need, it's not just enough to have one well-being officer. If we're going to have local champions, as Lauren was alluding to, we need to be able to support people in these roles in our institutions. If it's an add-on, it's going to go by the wayside. So we need to have leadership that values this, resources that we can develop, and we need a constant dynamic interplay between what's happening on the ground and what's going on at leadership. And often what happens is people say, and I think appropriately, things are local, you guys figure out what you need at a local level. And I think that that is important. It provides people with agency and investment. On the other hand, things usually get stuck there and people are not provided with the resources to implement the changes that they would like to make. So I think that in addition to everything else, we have to make sure that there are the financial resources to make these things happen. And that includes, and I know that Andrew and Steve will echo me with this, resources for providing mental health services. This is the stepchild of all of this. There, besides stigma and all the rest of it, there is a big challenge with access and payment, and that has to be addressed and valued as well.
Well, I appreciate that very much. Not scripted, but I'll give you my 2 cents on priority. And I think the priority needs to be sustainability. There's so much energy, particularly precipitated now by the burnout and the consequences of workforce loss due to all things pandemic. We will learn and have learned a great deal from this experience. There's a ton of ongoing research. There are countless pilot programs on every possible level in all of the accreditation bodies, professional societies, et cetera. And I'd hate to see that energy lost. And so we need to, certainly speaking for the National Academy Steering Committee, what we're looking for is make sure this is not the flavor of the month and that these become sustainable practices and continue to evolve. So we're pretty much at the top of the hour. Those are the 4 questions that at least I wanted to try to get through. What I'd like to do is turn it back to Dr. Clark and see if there's some question or discussion from this large group of those of you who have been listening so carefully.
Excellent. Well, thank you so much for those responses. And I will just send a reminder to all of you in our audience that this is your opportunity to engage with our panelists. You can please post your questions in the chat, either directed to the group, or if you have an individual you'd like to ask a question of, feel free to do so at this time. We do have a couple of questions that have come in, and also I'm sure my mind is reeling with a few questions of my own too. So we'll see how where these questions take us. We have a great segue to one of our questions you alluded to many times within our conversations today, and also presentations we saw yesterday about leadership and the role of leadership. We've also talked a lot about the role or importance of equity in decision-making and resources and access. One of the questions coming to us today is about how do we also ensure that the leadership that we have is representative of the communities that we serve, so that voices and decisions being made are those that are reflective of our communities. And that may mean many things to us broadly in terms of what we're thinking of, but thinking about the roles that we have in leadership and the representation within our leadership. I'm going to open this to the panel to see maybe who would like to start with how do we ensure that we have the diverse voices needed within our leaders to make the decisions that will be equitable for all of us.
Well, I'll sort of jump in if I can. First of all, you need people who are in leadership who understand the question. So I certainly think you need to raise the issue of appropriate representation. That's critical wherever we can have it. And that's why you need, we used to talk in a women's group at the APA about giving an award each year to a man of good conscience, somebody who really got it, who was a white guy, just to be clear about that. I think the same thing is probably going to apply in leadership, that you're going to have to start with the early adopters, with people who can model how you engage appropriate representation from your community. That said, I think it is important to understand sometimes that the perfect is the enemy of the good, and that we have to raise the questions, but that if we don't get the representation that we want, it shouldn't stop us from at least trying to move forward. But it really will help to have people who are in control, are in power, are in leadership now, who get it, for lack of a better way to put that.
Yeah, I agree, Dr. Bernstein. And one of the things that it makes me think of as well is a lot of times the initiatives that'll come from leadership are things that are more additive, right? We're going to allocate this task group to resolve this. And I think that has been a strategy that has shown smaller incremental change. But when we begin to think about what can folks in leadership do, particularly if that leadership doesn't reflect the community it's serving, is that's where those difficult conversations come in with ourselves and with other folk. So I might be asking myself, I'm representing this group of individuals as a leader. Is it the time that I create another position that will inform this work as opposed to delegating it to other folks? Or is it time that I move out the way? And I think as an internal conversation, that's a hard one to have, but I would love to see folk in leadership have that conversation more often and say, maybe I need to step to the side and allow folks who have the lived experience or have more knowledge in the area to do so. And I think that one of the barriers to that is that we don't give enough grace to have those conversations. Many times folks and leaders are expected to be the experts constantly and always, but it's not possible that we will be able to speak to the lived experiences of folks who we're intending to serve if we haven't had the opportunity to explore it in more depth. And sometimes we just cannot through barriers of what we don't even realize we are unaware of. So I think that that's some of the difficult conversations that I speak of, is asking myself, as a leader, do I need to create another role that can inform this so that there's adequate support for it, or do I need to move out the way? And so happy to help anyone process through that, right?
Dr. Stewart, that brings up a really good point regarding our own culture. In North Dakota, we have a large Indigenous population. And so there's been a lot of support given and resources given to not only individuals going into nursing and medicine from the Indigenous community, but we just began I think the world's only Department of Indigenous Health. And so I think that speaks to recognizing, but also providing the resources to be able to make that happen. And I think sometimes I used to think that mission and vision were kind of fluff, something that you just put in. But when you really fall back and look at that, particularly in difficult times, that can help to move you forward if people are being, as you say, being honest.
You know, Brandy, I think that representative leadership is critically important, and all organizations need to understand that and need to make a conscious effort to understand the best practices that are necessary to achieve as much representative leadership and as much diversity, frankly, in the leadership as possible, because that clearly adds to the strength of the organization. But that's a very time-intensive process due to contractual terms, due to board turnover, things of that nature. And there's a sense of urgency that has got to be addressed now in these areas. So as Dr. Bernstein said, we need a conscious effort by existing leaders to buy into this, to understand the cultural changes that are necessary, and to live this on a day in and day out basis, at the same time that we continue to work towards more representational leadership. If we were to await transformation in representational leadership across the healthcare delivery systems of our nation, we'd be putting this off for the better part of a decade, unfortunately. And we can't put it off more than another hour, let alone a decade.
Excellent points made related to that. And another question, and I'll continue to prompt just one more time. If you have any other questions that you'd like to ask, please put those in the chat. But I'm going to ask a question here that I think is related to doing a lot of this work, and especially the work that we're doing within the MHTTC network, our charge of providing training and technical assistance related to implementation. Time and time again, what we find it comes down to is infrastructure. We've got brilliant ideas. We've got great evidence-based strategies. It's the infrastructure for implementation is the pieces where we find that that's often what is needed to make things work. So I'm going to just pose this question to the group in terms of building the infrastructure to support organizational well-being. What are those critical pieces that have to be in place and sustained in order for this work to work?
I can start if that's okay. Again, we're just one experience, so take it with a grain of salt, but there certainly has to be money put into this. It can't just be volunteer work. And not only that, it has to be, like Carol said, not just one CWO. Like that one person cannot do all this stuff. So that person has to have a cohort of people that are also supported, that are a range of people. So one of the issues with our office that when we first started with it, we were very top heavy. Like we just had a lot of associate deans, and like, that's great, but we need people to actually do the work. So what we have done in the process is we've started to expand a bit, and we've thought about, you know, we have project managers and project coordinators and research coordinators, and we have students working with us all the time, and we partner with nursing, and, you know, nursing sort of ready to sort of put some money behind this too. So people have to be given time to do this work. They have to be given a structure. So you can't just like say, hey, go and do this. But I think it's really helpful to think about like the quality improvement structure as an example of sort of how you could build a similar well-being structure. Right? You need to figure out what the problems are. Then you need to figure out some potential solutions. Then you need to do your effort impact matrix and figure out which are the things that are going to be, you know, highest yield and, you know, lower effort. And then you need people who are actually willing to do the work. So it's money, it's resources, and it's structure.
Yes, I agree. I absolutely agree with that. And, you know, I think it's also about the time to give people opportunity to deeply invest in the value of it. You know, when I work with some of the folks who I have the privilege of serving in my work as a clinician, people who are service providers, they'll say, well, you know, there's not really much space here to talk about mental health because I have to do X, Y, or Z. And they're absolutely right. The work that they're doing in emergency departments is critical. And in that moment, there isn't that time. However, there's also not that institutional value that this is critically important. Is there the institutional value that issues around racism are urgent? Right? Is there the institutional value that trans and gender diversity has to be addressed immediately because folks who are in the space don't feel safe? And, you know, I think that a lot of times is something that we know that's important, but folks who are in the space to do the work aren't given the opportunity to do the critical self-reflection that's necessary for them to see how it impacts them personally, or to be able to process through the value of addressing these issues so that it can be personal to them, and like I said earlier, not additive.
I would just chime in, echo what Dr. Stewart and Dr. McLean, Dr. Peccarallo just said, and time. I'm glad you brought up time again, because I think to do this work, if it's going to be done deeply enough to be meaningful, it means time. People have to have the time to be able to do it and to meet and to think and to work it through.
Any other thoughts related to infrastructure? We talked about time, funding, resources, champions, roles, anything else that you might add to that?
No, I think there are some facilities or space related considerations. I think there needs to be some safe space for people to have these kinds of conversations. I think there needs to be some safe space for people to take a deep breath and you know, perhaps have that FaceTime with their child or their parent or with each other. And I think as we plan facilities in the future or look at existing renovation of space, we need to be very cognizant of that. I know we are, and we certainly don't profess to do it perfectly, but we do think about it and try to implement it as much as we can. I can tell you, we did a major facility of this nature for our residents and fellows for our GME program, and it had just an incredible impact on some of the survey data in the areas of wellness and resiliency that we have had and utilized in a tremendous manner, including reflection space, exercise space, place to get a cold or a hot drink if they need it during a long night shift, etc. And, you know, not terribly expensive, but very high impact.
Excellent. I think we have time for about one more question here, and it's usually what at the end of the day things come down to for a lot of this work is funding. And how do we sustain this work? What kind of innovations in funding and thoughts do we need to think about, especially in some of our medical centers where a lot of our driving forces come down to RVUs and productivity. And so I'm going to read this comment here and kind of get your thoughts or responses to it. So one of our audience members posted a comment that said, I heard a quote once that said that nonprofit organizations pick up where government has failed. It gets pretty exhausting when the immediate reaction is always get a nonprofit to take care of X, Y, or Z. So I'll open the door to your thoughts or comments and responses to that statement in particular in terms of how we fund the work we do.
So Brandy, I'm just going to say that it's probably a segue in part to the issue of nonprofits. What I hear all the time is apply for grants, get philanthropy, try to have them support this kind of work. The problem is that that's not, to use Jeff's words, sustainable. It just isn't, because you end up spending all of your time and energy writing the grants and the proposals to get the money. The resources for this have to come from operations. It has to be built in. I know that Lauren referenced the QI structure. I mean, I don't even know that we need a separate structure as much as we need to embed this work as part of quality improvement. But I think it has to come from operations, and that it is foolhardy to think that we can sustain this initiative by going to philanthropy.
Carol, that's exactly where we are at Mount Sinai. And I think that's one of the things that we're really proud of, is that our dean has invested in our office. And it's significant. It's, you know, I think one of the other things I wanted to mention, which I think has been really great, is that we actually offer an internal grant program through our office. And the idea is that we want folks to innovate internally to find solutions to exactly what you talked about. So to find a way to potentially improve efficiency while at least maintaining equal revenue, if not improving revenue, right? So if we can offer folks a little bit of money to like innovate and then, you know, see what happens, I think that's great. Because if we're just constantly telling people there's no money, there's no money, there's no money, do whatever you want to do with no money, people are just, you know, nothing's going to happen. But if we can internally do that, so you don't have that crazy external grant process, it's great. I mean, I know not every institution can do that, but it's not as expensive as people might think it is.
As somebody that has a lot to do with budgets in our institution, it's pretty clear to me that these are very valuable dollars that have a tremendous return on the investment. There's plenty of data on turnover and the cost of loss of resiliency and the impact of paid time off, hours worked to hours paid, etc., only exacerbated by what's going on at this stage of the pandemic. I think that becomes a communications issue that needs to be widely disseminated, because at the end of the day, if it's if it's doing the right thing for the right reasons and also happens to have a positive return on investment, that will just become the magic sauce for sustainability. I couldn't agree more. I think that outside nonprofit philanthropic funding is sometimes a way to get things started, to demonstrate proof of concept, but it can never really be a sustainable program. It will always be one of those things that's becomes a luxury item, the icing on the cake, and not the core of what we're doing. If we want to really have true sustainability, as our colleagues have said, you've got to build it into the so-called base budget, into the recurring budget of the organization, and then work hard to protect it. Because every time that there's a budget change, last thing in, first thing out, right? That's typically how it goes, and that's why determining the metrics for the return on investment. In other words, if it doesn't result in reduced turnover and improvements in hours worked to hours paid, patient satisfaction scores, and those sort of things, then there is no return on the investment. It's being done for reasons that may not have a financial impact. I'd like to believe, though, that all of that can be measured over time and fulfill all of those needs.
Yeah, absolutely, absolutely. I absolutely agree with that. And when I first read the comment in the chat, it also made me think of, I like to lean in that moment and see what the root of it is, right? A lot of times we'll defer, deflect things that we don't want to get involved with, or there's some underlying issue of commitment around certain topics where things get pushed off into other places. And so maybe it's also a place to say, okay, well, where do we need to lean in more? Where's the discomfort? Where is the lack of buy-in, or whatever it looks like that is also motivating a lot of the desire to put things off into other spaces and relegate things to be, taken care of by X, Y, or Z, right? So what is the X, Y, or Z, and what is the what are some of the underlying issues that are rooted in why a particular organization, a government, or a state, or whatever it looks like, doesn't want to address something directly? And so I think it can also be a little of that as well.
Excellent. I'm going to go ahead and we'll stop our panel discussion at this point in time, but I just want to say a big thank you. Thank you for all of you for spending the time with us today to share your thoughts, your perspectives, your practices, your expertise on this topic. It's been tremendously insightful, and I think a nice opportunity to get to discuss something that we know is having a really big impact on our field, and work that we know is tremendously important. And is why we're excited about this next part of our day, that we're going to get to do some interaction around this. Now we're going to get to do some planning and thought around how do we take this information back and implement it within our centers. So again, thank you to all of our panelists for your time today, your engagement today, and for all of you in our audience, thank you as well for your interaction. Before we move on, I just want to let you know that we do transition into another room, and that's because our presenter was there getting prepared, and it also allows us for some more interaction in the features of that next session. So you should have the link to that was sent in your materials, but I think we will also post that here in our chat for you all, so you can find it very easily. This will take you to our next room. I believe we have just a very brief break to get into that next space. The next presentation will be an orientation to our organizational well-being inventory, a new tool that has been developed for the purposes of within our MHTDC to support this work. So we're very, very excited to get to present that to you all. Again, thank you for your participation and engagement, and we'll see you in our next session.